I think we are very privileged to have Charlie with us this afternoon. I'm really thrilled that Help the Hospices in the UK stimulated him to do the work that he's done on palliative care. And I think a lot of it is relevant to us here in Australia, despite the fact that the healthcare system in Britain has some significant differences from our own, including a very extensive hospice movement that Australia doesn't have. But I'm thrilled that Charlie is able to be with us today, and that you all have the special opportunity to interact with him. So thanks, Charlie. It's all yours.
Well, thank you very much indeed, Steve, for that introduction. I thought I'd just talk a bit, and then you could have your tea, and then we could talk a bit more. But actually, what I was going to suggest was over the next, I think we've got 3 hours allotted for it. I could talk a bit, but you could talk quite a lot, and then we could talk together about the issues that around this. But perhaps I'll just give you a little kind of flavour of what I've been doing and thinking about, and then hopefully stimulate you to do some talking and thinking about it too, if that sounds okay. So I've written a lot about social innovation, social entrepreneurship, public service innovation, in education, in health. I've written about the internet, you know, all sorts of things. But writing about death and dying wasn't part of my kind of grand plan. It was something that I was kind of interested in a sort of theoretical kind of way. And I kept on thinking, as my parents got older, I should really think about what it's going to be like when they die. And I should prepare myself for it, because it's going to happen. But I should sort of think my way through what it's going to be like, how I should prepare, what I think we should do. And of course, every time I thought about it consciously to try and identify it and break it down rationally, it so spooked me, the thought of them dying, that I kind of just immediately dropped it and kind of couldn't somehow. I could analyse virtually everything else, but I couldn't think about that. And so I had, I can't remember actually the kind of the time frame of it, but I had done some work with Help the Hospices, and soon after that, a couple of months after that, so this is now 2 years ago, my dad, and this will be a completely familiar story to virtually everyone in the room, my dad was taken to hospital one day with a prostate problem. He had an operation to sort of clear the prostate problem. No one really explained what was going on. He was discharged over a weekend. There was no provision then of community care, or that kind of kicked in kind of 4 or 5 days later, by which time he was already kind of immobile and so on and so forth. He went in and out of hospital 3 times, and by the 3rd time, having got into urology wards, by the 3rd time I remember phoning up his 3rd admission and asking the woman on the phone where he was, and she said, oh, no, he's gone to ward 3. And that phrase, ward 3, obviously in that hospital meant something that I had no idea. I could tell that it meant something, I just didn't know what it meant. And what it meant was he's going to die, basically, because Ward 3 is where they put frail, elderly people with complex and multiple conditions they can't do anything about, and basically the people there, most of them are probably going to die. And that's what she meant, and that tag was probably kind of then understood throughout the hospital, but not by anyone outside it. And so we went backward and forward. He was determined to live. As he got iller, he became less able to have a conversation with. So the idea of talking to him about what he wanted was quite difficult. I'm not pretending it wasn't. But it wasn't made any easier by the fact that you couldn't find out who the consultant was. It wasn't made any easier by the fact that when you went to the desk and asked the hard-working but constantly rotating nurses, they didn't know what was going on. And I remember one of these nurses giving me the telephone number of the consultant secretary as if she was disclosing a secret. So I'm really kind of breaking the rules here. I'll give you her number and call her, and so on and so forth. And eventually we did have a conversation with another consultant who was standing in for the first consultant, and we tried to have a conversation with my dad, and basically they said, well, he's through the crisis and now it's like a long-term condition. He should, he may slowly get better, but we're sort of stabilizing it and so on and so forth. So despite our efforts to open a conversation about what was going on, unsurprisingly, doctors don't like having those conversations. Doctors like having conversations which are about healing and so on and so forth. Well, eventually one thing led to another, and my dad did die. He died on the morning of his 86th birthday, and he died, the cause would tell you he died of some form of asphyxiation, but he really died because of a complex of his underlying conditions and the bed sores that he developed in the course of his 6 months in and out of hospital. And it was basically the bed sores that killed him. And the bed sores were probably preventable, probably they could have done more to attack them. We did eventually get to see, and this is the most staggering part really, we got to see the consultant in charge of his case after he died. That was when they were ready to talk to us. And then we had an hour or so in which we kind of talked about what had happened to him. And it's sort of staggering really that you get that conversation after someone has died. And actually after that they were sort of quite good, They obviously didn't want a fuss made. They obviously didn't want legal action, and they talked to us. So my mum was 92. They'd been married 60 years, and she, although completely unable to walk, she was in a wheelchair. When we used to wheel her into the ward to see my dad, she would, despite being barely able to walk, she would get out of her wheelchair and clamber across all the kind of tubes and wires and kind of the guardrails to give him a kiss, and their eyes would light up. And it was that sort of sense that the ward wasn't designed for that. It wasn't, that was, you had to do everything in your power to kind of put it aside for that moment of intimacy and relationship, because the ward was actually designed for the people doing the work, and it was designed around their clutter, their routines and all the rest of it. And they were by and large hard-working, well-intentioned people, but they were in a system that was designed to make their processing of these cases easier rather than make it easier for relationships. So my mum's 92. She she was on various drugs to regulate her blood, and in the midst of all the confusion, in the 3 or 4 days after my dad's death, she forgot to take the warfarin that regulated her blood, and she developed a blood clot. She was rushed to Bradford Royal Infirmary Hospital, where a devout Muslim surgeon in his 20s saved her life. And she then went into a great ward which had incredibly personalised care. They knew exactly what was happening to her. They knew who she was. They knew quite a lot about her background. They had conversations with her. Actually, had she gone to Ward 3 in Airedale, they would have killed her off pretty quickly. But at Bradford Royal Infirmary, actually, they were pretty good. But ironically, about a week after arriving in Bradford, my mum, who had already lost earlier in her life one husband, said, I didn't really think I was going to go through this again, and I have no intention of going home, and I've got no intention of going to a care home. She had nothing really that she wanted to live for. She didn't want to live alone at home. She didn't want to go to a new care home. She said, I am ready to die. I'd like to die now. And she just kept on asking the people in the ward whether they could give her one big pill, in this kind of way that they could come round. And she would just say to them, can't you give me one big pill? And they'd just sort of smile at her and say no. Anyway, I think eventually they worked out she was going to die, because by this stage she'd been in there about 6 weeks, and she was just drinking Ribena. That was it. I mean, there was nothing else going in. And she was just slowly fading. And then they transferred her to a residential home just round the corner from where my mum and dad lived. And it was sort of heavy chintz. It was a bit like kind of bed and breakfast. Heavy chintz, pine, potpourri, but it was a warm, light place. It was opposite the school, opposite where they lived. Friends could come and go. And I remember the last time that I saw her, she directed me around the room. She could barely speak. She could just lift her hand, and she directed me around the room, and she just pointed at things and told me to move them. And then she said very clearly, "It's time to go." And she just sort of ushered me out. And so that was the last time I saw her. But my mum's death, unlike my dad's death, my mum's death was, it was a process of sort of completion. It was a process of sort of coming together. It was incredibly social. She had a real sense of agency. And because of that, she also had a sort of profound sense of dignity. My dad's death was a process of sort of fragmentation. It was a process of losing control, in which relationships played little role, in which the main actors seemed to be the medics. And there were unavoidable bits to his death. I'm not saying that it could have suddenly been magicked into something better. And, it was difficult to have a conversation with him about anything structured towards the end. So I'm not imagining that we could have wished it into something better. It could have been so, so much better. And it was the contrast between these two experiences that made me write this book, Dying for Change. And I've got, you can download it on the internet, but I brought 8 copies with me, so if you want a copy at the end, this is a kind of physical copy. And that was born of one thought, really, which is that, and I do this in talks occasionally, I just ask people where they think they're going to die. And basically, 95, where would you like to die? Basically, 95% of people say at home. How long would you like to sort of dying to take? Would you like it to take a few days, a few weeks, or a few months, year? Most people would like it to take a few weeks. Most people would like to be surrounded by their friends. And then you say to them, well, you lot over here on this table, that will happen for you, but the rest of you, that isn't going to happen. The rest of you, the sort of thing that really kind of impelled me to write it was the idea that more of us are going to end up in Ward 3, basically, in the UK anyway, unless we do something about it. That more of us will end up in versions of Ward 3 with staff who are run ragged and in medical systems which are not designed. Even when they're run well, they're just not designed to do what people need at the end of life. So that's what led me to this project. And I'll just quickly run you through. I've got 3 little chunks. One is about the problem, one is about thinking about solutions, and one is about taking action. And so perhaps between now and the much needed tea, I'll talk about our understanding of the problem. So I just set off, as you've found, Kerry will have found, everyone involved in palliative care will have found, one of the things that we found was it's incredibly difficult to get people to talk about it. So people will talk about death, they will talk about what it might be like for them to be dead. They find it very difficult to talk about dying. And so the actual process of trying to research this is very hard. And this is then, of course, very important for any kind of innovation, because it's virtually impossible to innovate unless you have some sort of iterative, interactive relationship with people who can tell you whether it's working or not. But this, you're often dealing with relatives who've got their own vantage points on things. So actually assembling that sense of what's needed is poses its own challenges. But with the help of people like Heather Richardson and David Prale at Help the Hospices and others, we did some work on the internet. There are some sources on the internet, narratives on the internet, but quite a lot of interviews and case studies. So most people won't die where they would prefer to. 2/3 of people, we did a national survey in this, 2/3 of people say they want to die at home. By 2030, 1 in 10 will die at home. It's very important, this notion of home, what it means. Is it a place? Is it a feeling? Because, as I'll come on, actually as a place, it's got significant limitations, which it's a very idealised space. Only 9% wanted to die in hospital or a care home, but 85% would. And so there's this sort of huge mismatch between what people want and what they're going to get. And so what we set out to do in this was to try and describe the elements of what a different kind of approach to dying would mean and how we could put it together around this idea that what would it be like to try and allow people to live as well as possible right to the end of life. And one of the things that I think is very true about all innovation, but perhaps especially in areas like this, is the question you ask really matters. What's the question you're asking? Because if the question you're asking is, how do we get more people out of hospital? That's one question. How do we get better palliative care? That's another question. But how do you live well is a completely different question. Because better palliative care might be the better provision of professional services in different settings, but living well is a completely different question. So it really matters what the question is and whose question it is before you go rushing off for the answers. So dying, 3 or 4 features of dying that are very important that we thought to take account of. That dying is basically complex. It's not simple. It's not, well, some instances it is, of course, that someone has an accident, they die, someone has, a kind of life-threatening disease and they die, and it all happens. But for most people, dying is an unfolding, complex kind of experience. It's not linear because it kind of can be corrugated. The physical and biological elements of that are different from the social and the psychological elements. It's got many different dimensions. It can be medical, physical, social, spiritual, so on and so forth. The big implication of this, we think, is that you cannot design linear pathways for it. It's not like designing a service pathway. You can have bits of that, and you can have ingredients of service, but you can't say this is a good death. And I think there are people, perhaps some in the States, there are, for instance, people who've got quite a prescriptive idea of what the process of a good death is. We think it's just too complicated to be able to do that. The second big thing is, of course, that dying is concentrated amongst the old, and that most people die over quite a long period in slow stages, losing bits over a long process with multiple conditions. And so this just adds to the complexity, but also compounds with all sorts of problems. And so one which came out very strongly is that in the UK, at least, cancer deaths are talked about, researched, and relatively well provided for, but COPD, frailty, multiple conditions, diseases of real old age, they are very much less talked about and much less provided. And the whole hospice movement is built up around cancer, whereas the big need is really about these kind of other kinds of conditions and what have you. Dying, very difficult to talk about. So for some, again, this is why it's very important not to be overly prescriptive. There are lots of people who would say you have to talk for something to be a good death. Unless you start talking about it, you can't get it out into the open, people can't respond. But for some people, not talking is absolutely a precondition of a good death. Some people just don't want to talk about it. Some people would prefer to sort of almost create the impression, the feeling that it will come suddenly and unexpectedly because they're not going to talk about it. Other people do. What is clear, I think, is that if there are more people who would be prepared to talk about it, we don't make it very easy for them. And we don't make it very easy for them because no one really knows how to have those conversations easily. Medics are completely ill-prepared, and in my view, the wrong people to have those conversations. Relatives and peers would need more support. And you'd need to do it over a much longer period of time than doing it when someone is dying is way too late. And anyway, having a conversation about dying is not the right conversation, because really what you need to have a conversation about is about living well. And really the conversation should be about what is it that means that you can live well even at the end of life. Encouraging talking is very, very important. So there's no single idea to a good death, but there are common ingredients. sense that you're dying at the appropriate time of life. Death can, of course, strike too young, too early. We feel that's tragic. But as big an issue now for many people is the idea that they're living too long. Actually, the sort of very strong sense that came through a lot of our research of, because I don't want to linger, I don't want to hang around, I want to drag it out, I don't want my quality of life to sort of decline. Degrees of control, feeling to some extent that you have some sort of agency or capability, having the right relationships, absolutely critical, and avoiding pain. Of these, when we asked people what the components for them of a good death were, or what they would want around them or close to them at the end of life, basically it's being in the right place with the right people is the most important thing, and then having access to medical support as the sort of the next thing down. But it's very much that balance. It's about being with the right people in the right kind of place and the medical support coming in when needed, rather than having the right access to pain relief and medical support and trying to fit the relationships into that. If you take some of those ideas about dying, how do our current services stack up against that? Well, hospital is familiar. Most people will have visited before. It's got a kind of pattern of authority. People know what they're doing, apparently. It's 24/7, which is important. And it's sort of contained. You know, it's there. You go to it, you leave. It doesn't follow you around. It's not everywhere. It doesn't seep into every room of the house, so on and so forth. And so it's got huge attractions for people, and particularly around crisis management and pain relief, because if someone you love is in pain and in a crisis, and particularly if the crisis hits at night or over a weekend, hospital is the place to go, basically. And a lot of people end up in the UK in hospital at the end of life because of crises at night and at weekends, and because there's nowhere else to turn to and they don't know what to do, and so they end up in hospital, and basically they go in, they go out, they go in, and usually then they never come out again, or they might come out right at the end to go to a care home or a hospice. So the trouble with hospitals is that they focus on conditions, not people, really. They see conditions, they don't really see people. They haven't got time for people. They've got time for conditions, and the more specialised that hospitals have become, the more conditions they see. So the more clinicians you're likely to see in a given episode, the more likely you are to be moved around, and they are impersonal but cold, basically. That's the thing about them. So they save you, they might give you absolutely vital things, but they kind of take something from you at the same time, in a way. I have a friend whose daughter was very, very ill right at the start of life and went into intensive care and was saved, and they were absolutely brilliant. She was in intensive care for 6 weeks, and he says you could tell when something really, really serious was happening because they'd start being nice to us and they'd sort of make us a cup of tea. And then when the crisis passed, they'd just go back to kind of being how it was. And it's a sort of savage kind of thing, but that is kind of true, is that sort of that sense that, you know, I remember when my dad was right at the end, they said, you can come anytime you like now. It's like you're kind of granted this sort of special visiting rights, you know. Do you know what I mean? But most of the time, they couldn't afford in their own minds to let it be anything other than a fairly kind of impersonal thing. So if the psychological and the relationships are vital to living well at the end of life, then hospitals are pretty poor. Care homes are absolutely essential part of that end of life kind of economy and activity. Especially they are hugely important for people with frailty and COPD. But care homes, very variable quality, very low quality of staff, very little training, poorly paid. They're largely disconnected from medical services, and so as a result, because medical services aren't well connected into care homes when there's a crisis, the care home then sort of thinks it has to transfer the person out into the medical service. You know, a lot more will happen in care homes, and they need to be part of improving care homes and reimagining them must be part of the future. Hospices, Steve, I don't know enough about Australia, but in the UK we do have this hospice movement. It has been really, really important and very influential. Most of the innovation in the rest of the system, particularly the medical system, has come from hospices. So even if hospices only account, as they do, for about 7% of deaths, actually their innovations have affected the rest of the system a lot. They get very high satisfaction ratings from people who've dealt with them. They have increasingly innovative. The best hospices are both providing in-hospice care, but also a massive out-of-hospice care, outreach care. So the best hospices are going in this direction. So they're very important, but they tend to specialise on cancer. They're increasingly in the UK becoming part of the system rather than a sort of source of innovation or challenge to it. The public perception of hospices is dreadful. I mean, they are basically seen as places of death, completely at odds with what they're like. I mean, I went around doing this research, spent a year looking at places where people die. The only places I ever felt like staying were hospices. The only places I ever felt like having a cup of tea or sort of chat, oh, this is quite nice, I can talk to people here, kind of quite warm and friendly, and seems to be quite a nice buzz. It was a hospice. Never ever once felt like that in a hospital. But that perception is completely at odds with how people see them. People see them as dark and threatening places. My kind of view on the whole hospice thing is that it's the philosophy that counts. The institutional expression of that in a hospice, a place, is very important, but it's really the philosophy. And the real challenge for the hospice movement is how do you get more people to enact that philosophy in different settings? And then finally, home. Home is the sort of, idealised place of dying for most people, because it provides a sense of intimacy, relationships, maybe control, because at least you're in your setting, people have to come to you. And a lot of dying does take place at home over a very long period, and perhaps only right at the end that people leave and go to other settings. So it's still very, very important over the longer picture. But the caring capacity at home, particularly for these kinds of deaths, in a world where most women work and they've got multiple commitments and other things, is absolutely huge. And the people, whilst most people want to die at home, if you ask them, would you be capable of looking after someone dying at home, only a quarter of them would. So the mismatch between, I'd like to be looked after at home, but I can't look after someone else, basically, is the kind of story. So, and home, I think people underestimate how changed by dying home can be, that never isn't the same afterwards, and so on and so forth. So home is a very difficult place to just conjure up, let's get more people dying at home just like that. You can't do that, because that would be putting too much of a burden on people. So I spent a day at a hospital in Salisbury, Wiltshire, and in the morning I did a session with all the clinicians involved in palliative care, and they basically, what they said was, we have 1,000 deaths in this hospital a year, 500 of them don't need to be here, and probably 250 of the other 500 don't really need to be here, but we could kind of get them out if we really tried. Only probably 250 really needed to be in a hospital because there was something potentially we could have done, but we didn't manage to. Most of the others, they were already dying when they arrived, and they were only ever going to die, basically. So one clinician who was Australian said she'd done her ward round that morning. She had 8 people on her ward. 4 of them she could do nothing for. They were going to die. So their kind of whole thing was, we're dealing with people we shouldn't be dealing with. We don't want to be dealing with them. We know this is the wrong place, all the rest of it. The afternoon, I had a session with people who were terminally ill and their carers, and they basically said, there is no way that we're going home. If you think you're just going to turf us out and our relatives are then going to have to look after us. And so our last bequest to our relatives is to make their lives more painful and difficult. You better think again. We want proper support, and if we can't get proper support at home, then we'll come to a hospital. And it's imperfect, but that's the cost that we'll pay, because we are not prepared to burden our relatives in that kind of way. So it's clear that home is an idealized place of dying, but actually realistically it's impractical for lots and lots of people. It's just not going to work unless they're properly supported. So this is where we are, and perhaps we could just kick off our conversation around this. The space for innovation is all about the relationship between these three things: what we have, what we need, and what is possible. And if those three things are closely aligned, in other words, what we need is what we have, and anyway we can't imagine doing anything different, then there's no space for innovation. But if they pull apart, then the space for innovation grows. And what's happening with aging and dying is that it's pulling apart. And the job of social innovators, the first job, is to make that space bigger. What we've got isn't good enough. It's absolutely crystal clear and needs to be made more and more clear to push. I mean, the problem with this agenda is that no politician wants to touch it, basically. There are no votes in it, they think. It's completely unsexy. The resources in the health system are diverted away from it. No one wants to touch it. It's a huge Cinderella issue. 500,000 people die each year in the UK. No one wants to really talk about it. So the first thing is we've got to get people to talk about why what's happening isn't good enough. First of all, what is happening? Just what is it like? The degree of ignorance about what it's like is it's happening to thousands of people, and yet no one's talking about it. So we have to get that out into the open. The second thing is that what we need is changing, and what we need is changing because the way we die is changing. The way we die is changing because it's more prolonged and elongated at old age, but also because of the values that people bring. So what we need, our values are changing, and so the question is what is possible different? And if those three things do change, and I think this is really critical, can we really imagine practically different things that we can really talk to people about and do, not just kind of aspirational things? Well, then the space for innovation grows, because then what you're saying, look, is what we've got is way not good enough. What we need is changing, and so it's completely out of step. And actually we have got new ways to organise what we do and spend our money and create new ways to create better solutions. And the first thing that all social innovators do, in a way, and they do it continually as they innovate, is keep that space open. Because the moment it closes down, it becomes more difficult to innovate. So the question is, you can get that when those three things change. So how do we open that space up? Those three prongs. What we have isn't good enough. What we need is changing. What's possible is different. How would we, and at what level would we do that? Would you do that at the level of a town, at the level of a state, at the level nationally? And what are the most effective ways to get the right people involved in that kind of discussion in order to open up the space for innovation? So that, I think, is the first question I was going to pose. The really big difficulties are about how you cope with the diversity of what people need, and how you cope with basically entrenched systems that don't want to change. Those are the big challenges. And to bring about change of that kind, you need to operate at all sorts of different levels, it seems to me. You need big community-wide campaigns which are about the big issue, but you also need to empower people quite locally. You need a very strong sense of cause, and crucially you need to build coalitions. You need to build coalitions of the willing, whoever they are, whether they're doctors, nurses, palliative care specialists, hospices. There needs to be a kind of broad coalition of people who come together around a cause, and that will bring change. So how do we fill the space? Well, we thought that there were kind of four basic kinds of innovation that we saw and that people could focus on and that people looked at, and that they were these basically. They were either you improve what you've got, you try and reinvent what you've got, redesign it, you try and combine what you've got up in new ways, so the ingredients are there but you haven't managed to combine them, or you try and transform it. And let me just quickly, each of these is relevant, so I'm not suggesting there's a hierarchy necessarily, although I think I will argue that some are more important than others in the long run, but each of these plays a relevant role, and the dilemma is which to look at. So if you look at improving what we've got, well, there's a huge role for advanced care plans, just to equip people better to have answered questions earlier, which will, when the crisis comes and they're in hospital or what have you, they've got something that they can kind of go back to. They've had some kind of conversation. The spread of non-specialist palliative care, so that palliative care becomes something that's much more generally aware, people are much more generally aware of. Doctors like Suzanne are kind of the common thing, not less common. And crucially, patient involvement kinds of voice. So there are lots of ways in which the current system could be improved. An example in the UK is the Liverpool Care Pathway. The Liverpool Care Pathway is really at the last kind of, I don't know, 48 hours often of dying, where a kind of completely different kind of set of sensibilities and services kick in. The problem with that is that it's very late. I mean, last 2 days is very, very late in a process that will have probably gone on weeks. And it can become a bit pathway-like. It can become a bit tick box. But it would be mad to think that given how much we spend on hospitals and, you know, that we neglect this kind of area. But we also know that this, as a result, is a very long haul, I think. Changing hospitals, changing medics, changing routines, shifting power, changing the language. I mean, we can all imagine how it can be improved, but actually it's going to be quite a long haul. And the possibility is that despite, you know, the best efforts of enlightened practitioners, if actually hospital is the wrong place to be because you can't be cured, and there isn't very much that doctors can really do for you as doctors, then trying to improve the wrong thing doesn't necessarily make it better, because you're already you're in the kind of wrong kind of place. So the second thing, which we see quite a lot of, is then people saying, okay, well, the ingredients are all there, it's just that they're very disconnected. And what we need is that often people need different things at different stages. They do need at some stages to be in hospital, but then they need to come to care homes. They might need a hospice right at the end. They might need care at home. And actually what we haven't got is kind of people joining all that up. And so Marie Curie in the UK has done a lot of work with discharge teams in hospital. I mean, literally going around hospital and finding people who want to leave. I mean, not waiting for them to put their hands up and demand to leave, but literally hunting people out and saying, do you want to leave? We will get you out. And we will organise it for you through this myriad of transport and ambulances and social care and community nursing, all the things that need to be put together. We will organise that for you. You would definitely need better care planners and navigators to connect that together. So Age UK now has sort of palliative care navigators who help people in the last year of life. And somehow, what I think one of the big opportunities must be in trying to improve the quality of care in care homes. That there are so many people in care homes that actually bringing to care homes and connecting them up with hospice philosophy, if you like, creating some sort of new hybrid there would be important. And I mean, your comment about Wollongong is that I would put sort of as a sort of prototype of this kind of thing, the End of Life Trust, where you can imagine a community where instead of having voluntary, hospital, private, actually you created some sort of communal basis for thinking about end of life in toto. So you had people sort of thinking about it and commissioning it as a community in its various forms, bringing it together. That might work. But there are all sorts of ways in which the current system is very disconnected, very consumer unfriendly, and you could simply make it better. And there are a whole host of things you could do there. So the third thing is you could reinvent what we've got. And that by and large means taking things which are sort of familiar and then giving them some complete makeover to try and repurpose them around different kinds of goals. So taking medical settings and making them much more open to the social, the spiritual, the psychological. So if you look at Maggie's centres in cancer, they've done that. They are completely different spaces. They've got a different ethic. They provide very good medical care, but they're not just about medics. And many of the best hospices are like that. They're familiar, but they feel different at the same time. The thing that, I mean, the big things that we thought here, these are 4 ideas, some of them completely bonkers, but I mean, I'll start with the most bonkers idea. The most bonkers idea is the home hospice, which is that if we have foster carers who use their homes to foster children, could you have foster hospices? In other words, homes where people die but they're not their homes. So this would imagine a sort of whole host of people who would be like kind of social entrepreneurs in death and dying, and their homes would be places where people died, but they wouldn't be the person's home. So this is where we ended up. This was what we thought was the best approach to where we thought people wanted to be, which would also actually be affordable and generate better outcomes for people, which was not a different version of what we got, but a social approach, which was much more a with approach than a for and to approach. And that it would have these kind of, I suppose, vital ingredients. One is, can you increase the capacity of people at home themselves to support? So compassionate care leave in Canada, I mean, supporting the primary carer, both financially in terms of time, but also in terms of training. So it's quite an interesting scheme in Canada, again, Victorian Order of Nurses, of peer-to-peer training of people being involved in palliative care, helping one another. And there's also still, although shouldn't be overestimated, I think interesting applications of technology. I mean, basically, when talking to people with disabilities, what they say is, we don't want people coming into our home, but we do quite like technology that allows us to keep ourselves at home. And there's still quite a lot of assistive technologies and things that we haven't. So one would be to support the capacity within the home. Second would be to provide people with key relationships. So what people said time and time again is, we want someone who knows us, is the same person, and who knows what we need and can articulate the rest of the system to us. And even if that person is just on the end of a telephone, that's still useful. And you don't even have to talk to them. Just knowing they are there is a huge help. So if you just manage to create a telephone-based support with a single sane person all the time, 24/7, that would make a difference. And then again, the role of volunteers. So I think there's a big debate about that, about how far that can go. The hospice movement has generally used volunteers to raise money, make tea, that kind of thing. It hasn't developed them as care providers, advisors, mentors. They would for sure need proper training. For sure you'd need to make sure they didn't burn out or they didn't find themselves in positions of risk and vulnerability, but there's a huge possibility. And then you'd need to make sure that you've got services coming to home when needed, and that they could be called upon, whether it's hospice at home or emergency support or kind of crisis teams, to keep people at home rather than crisis tipping people into the system. And if you just did those 3 things, support within the home, key relationships within the home, support to the home, then you could make the home much more the centre, and community much more the centre, rather than the institution, and work with people. Now, what are the ingredients of that? Well, the ingredients of that are all around the place. All the ingredients of that exist. None of it needs to be invented, and none of it is rocket science. So the most exciting, I think, Kerry has been to in Kerala, the Neighbourhood Network for Palliative Care, Suresh Kumar, 10,000 volunteers. Germany, they have thousands of volunteers involved in palliative care. But in Kerala, that Kerala project, they've got some very simple yardsticks. One is no one dies alone. The second is as soon as someone becomes bedridden, they become part of our world and kind of we're concerned with them. And when I talked to the guy who organised a lot of these community drives, I said, how on earth did you get all these people involved? He said, they think it's fun. They think it's fun. They've managed to make palliative care, death and dying, fun. It's something to aspire to be involved in. It's an amazing trick that they've pulled off, but that's what they've done. They've made it something to really become engaged in. In the States, Aetna's hospital programs had amazing results, and so is a model for what you can do with private insurers to get them to fund it. And La Crosse, Wisconsin, where the clinicians, actually Suzanne's kind of equivalents, have led the charge and developed over a long period of time a very simple sort of question and answer based kind of approach, which they introduce kind of around the age of sort of 75 with most people, and people just ask the questions and they have conversations about what they want in the last years of life. And so that means that when they come to the very end, they've already had the conversations. They're not going to have them then, they've already had them, which means they're better prepared. And so how would you get all of that going? Well, this is one way of thinking about what we're trying to do. This is, if you just divide the world into, if you like, high system ways of doing things and low system ways of doing things. So high system is regular, reliable, repeatable, professionalized service protocols, so on. Those low system is very bespoke, individualized, probably kind of each case different. And then you think about the world divided into experiences which are high on empathy and low on empathy. So this is a scheme devised by a guy called Simon Baron-Cohen, who's an expert in Asperger's and autism. And he says that Asperger's is people who have high system, low empathy. So they can systematize the world, they can think in numbers, but what they can't do is relate to people. So if you use that and then think about what we're trying to do, this is the worst place to be. In virtually any kind of setting, it's low system, low empathy. And interestingly, the two often go together, because if there's no system to rely upon, actually trust often breaks down, people scramble for resources. This is where I went to school. This is the Vine Comprehensive School in Basingstoke, circa 1973. 2,500 barely contained children beating the crap out of one another. There was no system and there was very little empathy. So you can go up here, and this is better because at least there's system, but often the system comes at the price of being cold. So if you've ever been on a kind of really bad low-cost airline, that is what that is like. So it's sort of highly systematic and efficient, but completely cold. And actually, too much of the time, public systems are a bit like that. They're systematic, they process, they have protocols, but they don't relate. So down here, you can get this, but often this is very personalised and small scale. It's very difficult to scale because it's very personalised. It's very rich, rewarding. So this, my wife and I, every Saturday morning, we cycle to a farmer's market just down the road where we buy the most expensive tomatoes in human history. And we do it because we think it's a low system, high empathy experience, because we talk to the tomato seller. And then we go home and we buy our vegetables, the rest of them from some high system, low empathy internet provider. But that is basically what we spend a lot of our lives doing. We go between these experiences, and when we've had enough up there, we have something down here, or we catch a low-cost airline to go to a boutique hotel or something like that. Or, do you know what I mean? And I think that where we are, by and large, in a lot of our systems, is that we kind of think, okay, we'll give you a little bit of that to make up for that. And we kind of bib and bob between these two. And actually, where we really want to be is up here, which is where you want, as I said, you want intimacy, but at kind of scale, and you want systems that support relationships. That's what people want, because they do want systems, they do want reliability, they do want professionalism, they do want service, they want to know someone knows what they're talking about, they want to be able to depend on things and stuff like that. But they want meaning, and they want intimacy, and they want relationships, and all that, and they want things that can bring those two together in the right kind of way. So Grameen Bank at its best is a system. It lends millions and millions of dollars, but it does it entirely through relationships. Facebook would claim to do that well. There's an amazing HIV network in Africa called Mothers to Mothers, which is a network of HIV positive mothers mentoring other HIV positive mothers, which was invented or developed by an American doctor called Mitch Besser. And so Mitch went to South Africa, and he was an expert in mother-to-child transmission of HIV, and he knew that in America rates of mother-to-child transmission had gone down like that. So the system, in a sense, worked, the drugs worked, he knew that. But in South Africa, mother-to-child rates of transmission of HIV were massive. I mean, 95%, something like that. And so he spent 2 years trying to work out why mothers wouldn't take drugs. Why won't they engage with the system? We've got the drugs, we'll give them to you, they will save you, they'll save your baby certainly from having HIV, and still they wouldn't take them. And he tried all sorts of things, and then finally, one day, he saw a mother who was HIV positive, who was older, with a mother who was younger, advising her, bringing her to the clinic, and that woman stuck the program. And it was then that he realised that what he needed was system and relationship, and the relationship was the mothers. And so the mothers, because of the empathy, so the mothers deal in Africa, they deal with people who other mothers who are living in worlds dominated by men, and kind of all sorts of superstitions about AIDS, huge prejudice and discrimination, all the rest of it. So in order to engage with the system, you need huge amounts of support. They train the mothers, so they train the mental mothers, and they now deal with 250,000 women a month in 9 African countries. So that's a system that delivers stuff through relationships. If you think about the best experiences you've ever had at school or learning, the best schools are systems and relationships. Their learning is structured, coherent, it's got someone sort of designing it, but it's very kind of empathetic and relational and all the rest of it. So the best schools and learning experiences are like that. And if you think that basically all our experiences in these areas, I mean, actually dealing with the unknown, so it's a learning experience basically. You're learning the whole time. There's no preset kind of program. You're having to adapt. That's what it needs to be like. But if you go too far that way, you get too much system, not enough empathy. And if you go down here, you've got lots of empathy, but not enough system. So there are things, but that I think is what we're trying to create. And so if we go back to what this looks like, this is how do you create a system which supports relationships and empathy. And Kerala, that is what Kerala is. Kerala is a system for delivering and making available palliative care for supporting people at the end of life, built almost entirely on structured relationships, into which medical knowledge is inserted when it needs to be. So that, I think, is what we need. What would we... These are my final thoughts, and how do we get it going? Well, one is money. You raised the issue of money. The first thing is, no one knows how much it costs, basically. I bet no one in Australia's got the slightest idea how much the whole palliative care end-of-life bill is. They might know a bit about the healthcare costs, but I bet they don't know about the total costs. So first of all, we don't know what resources are involved. So we just looked at the NHS costs, and we estimated them currently to be 20 billion and probably 25 billion. So there's big resources in this area already. And we reckoned that you could easily invest 500 million and create a 24/7 support service, hospice at home service that could cope with, say, 90,000 people, a volunteer program that could train 100,000 volunteers. So in other words, for an upfront investment of £500 million, you could create an entirely new system. And the new system could cope with a very, very much higher number of people, probably 50%. And this is a case study of one project in Birmingham North and East. So the northeastern area of Birmingham, they have 4,000 predictable deaths a year in Birmingham. Each of those deaths, on average, involves 3 hospital visits in the last 6 months of life. That's 12,000 visits, lasting 5 days on average, 60,000 hospital days at £250 a day in Birmingham North and East. It's a lot of money. So that's 15 million a year. They commissioned a healthcare at home service from a provider called Healthcare at Home. The costs are 30% lower overall. And the first 500 people who went through that service, there were 5 hospital visits in total. 5 hospital visits in total. 500 people. So just imagine the scale of that. And that's simply just providing basic levels of support at home. You can have it, it will come, it's reliable, it will be the same person. There's someone on a telephone in case you need it. There's someone down the road. I mean, they hadn't even done all the things that you might do. They hadn't really trained volunteers. And they'd already had the big challenge there, which is, of course, the hospital beds just got filled up. The hospital beds didn't go. The money wasn't freed up. The hospital just used the opportunity to fill the beds up with other cases, for which they charged more money. So the big issue is both how do you create the new, but how would you take money out of the old? So we think if you just did this, advanced care plans, home care support, dedicated discharge teams to make sure people could get out if they wanted to, this volunteer program, probably personalised budgets to allow people to spend money in ways that they really wanted to, and integrating health and social finance for care, you get a completely different system. What would it take to get that going? These are my thoughts, and I'd be interested in your views. But basically, social innovation is about communities with a cause, basically. Innovation comes from communities with a cause. It comes from groups of people with different ideas who are animated by some kind of cause. And the cause propels them to challenge the status quo, to go somewhere further, to try a bit harder, to mobilise other people. The community brings different ideas, reach, mobilisation of resources. And so, what's your cause? That's the most important thing. What is it that you're really for? Or, if you like, who are you really for? That would be the first thing. What's the community? I think that one of the things that you have made clear is that if the cause is living well, the community must be anyone who believes in that, no matter where they come from, what they've got to offer. It's got to be as inclusive as possible. And one of the key, I mean, in our innovation projects, there are all sorts of people who are important. There are politicians who are often important to sort of set the kind of overall kind of framework. There's often users, consumers are important to tell the story from their point of view. Innovators are important to come from the outside. But absolutely critical are kind of people who are on the edge of the system inside and outside. So they are a bit like kind of renegades. They're people who can sort of talk to the system, as well as sort of having credibility with the system, be critical of it. So people who are sort of allies inside the system, but can see how it needs to change, who are like swing voters. Because in a sense, it's like building a kind of network or an alliance, and you have to get as many people in it. Framing the question is critical, because if you're framing it around better pathways to care within hospitals, that's what you'll get. But if you want better ways to live at the end of life, you need to make sure it's framed in the right way. If you like, asking the right question. And people with a cause need to challenge things. And you will need to challenge conventional wisdom, vested interests, the status quo. And unless you're prepared to do that in really tangible ways, you won't get change. And you have to make a commitment. No, innovation doesn't happen without a commitment. It doesn't happen without people really committing. So Sophia Christie, who commissioned that stuff in Birmingham North and East was she'd had all of the discussions that we'd had. It's not good enough. People want something different. We could do it. And she just said, okay, we are just going to do it. We are just going to take that step, and we are going to put some money on the table. The guys at Marie Curie, Tom Hughes Hallett, similarly, they put some resources there to carry out really quite small scale but very powerful innovations which have had a big impact. So you have to commit, and someone has to commit to create the community. So it can only happen with a community, but the community won't get going unless someone commits to sort of put something in place to kind of for people to organise around. And what finally would be your measures of success? So again, that's important because you can find those setting you off in the wrong way or getting hijacked. We have found time and time again that if saving money becomes the measure of success, people stop innovating. Is that it closes it down. So you have to be animated by doing something better for people, and it's very important to define that in the right way that really animates people. So if you've got all of those things together, what's your cause? Who's our community? Whose vantage point are we trying to see this from? What are we going to challenge? What should we commit to try and create this community and get it going? And what are our yardsticks of success? Then I think there's every reason to think we could do something completely different. And it's not rocket science, and it's not expensive. It's less expensive than what we currently do, and it will deliver better outcomes for people. It's just that we have to kind of break through, because otherwise it will remain this kind of thing that happens under the surface that no one talks about and people cope with privately and all the rest of it, but it never somehow surfaces in a way that allows society as a whole, those not directly currently involved in it, to address and think we need to do something different, and it matters. It's been a great discussion for me. What I've observed is, just writing the report to be honest, is that looking around the world, one of the places that definitely you would look for innovation from is Australia. That when I look around the world for places that innovation was coming from, places that you might expect it to come from, like Sweden or Denmark, which are often sources of innovation. Actually, in this field, Australia definitely is. So that's the first thing. The second is that all the ingredients of what you want are already here. It's about bringing them together, and it's about finding the right cause, really. It's finding the right cause, articulated in the right way, that pulls together a kind of creative community that can really start change. And I do think that Kerry is right, that you have to find some mix where basically you have to commit to doing things, basically. That voice and advocacy really matter to create the framework, but you have to match that by doing things. And I think it is completely conceivable that within 10 years you could completely change the way people die in Australia. It is not out of the question whatsoever, because everything is here, but it would be a question of finding the right way to mobilise that. Perhaps at the level of a city, compassionate cities, communities already doing that. Perhaps the level of the state, coming out of a hospital that really wants to change things, it might come from many different places, but it needs to be brought together in great momentum. And I'm sure, absolutely sure, that all the ingredients are here. It's just a question of kind of creating the right kind of recipe to kind of make them all work. But you could definitely do that, and thank you very much indeed. I've really enjoyed it.